Luke Wolfenden. I'm a Professor of Public Health at the University of Newcastle and Director of the National Centre of Implementation Science. I'm also on the Leadership Executive of the Prevention Centre. I'll just start formally by acknowledging the traditional owners of the land that we're meeting on today, wherever we are, and paying my respects to elders past, present and future. I'm on Awabakal country, a country that has never been ceded. So I'm very much looking forward to the event today. We're hearing from researchers and partners engaged in a multi-jurisdictional program of work to improve maternity care and mother and child health. So the work's been funded by the Australian Prevention Partnership Centre. So I wanted to kind of acknowledge their role in funding this work, but also brokering the partnership and organising this event. These types of research practice partnerships are really important vehicles to ensure that research that we undertake is relevant and that the knowledge that is generated is also rigorous and can contribute to the broader evidence base. So I'm really looking forward to this research seminar today. So I'll just walk you through the outline for the webinar. So we'll have presentations from the research. So we'll have 2 presentations outlining the findings, and that will be followed by a panel discussion. You're welcome to add questions as we go, but we'll hold questions for the panel discussion following the presentations, and the microphones will be disabled during the presentations, but will be open during the panel discussion. So please, if you've got any questions, add them to the chats. I'll pick them up and I'll ask those questions of presenters or of panel members, and you'll also be able to ask questions as you go during the panel discussion. So I should also mention that this presentation is being recorded today. So that's just to let everyone know that that's the case. And so we might make a start. So maybe I'll move into the presentations, and I'll first introduce Melanie Kingsland and Sophie Dilworth. So Melanie and Sophie are researchers from the University of Newcastle and Hunter New England Local Health District. And they've led the research that's being undertaken over the past couple of years, and we've presented today, and they'll really walk you through the key findings of that program of work. So welcome, Mel and Sophie. Very much looking forward to your presentation.
Thanks, Luke. Yes, I'm always looking forward to presenting on the work that we're doing in partnership, because I think it's really valuable and it's a great opportunity to share really the outcomes and the benefits of working in partnership. So thank you for all joining today. I'd like to reiterate how thankful we are for the funding of the Prevention Centre and all of the partners in the Sachs Institute for all of their work that they do to bring these projects to reality. I also would like to make a big thanks to all of the partners that participated in this particular project from day one all the way through the 2 to 3 years, which of course went over all of the COVID disruptions. We had Women's and Children's Hospital in Adelaide, Wellbeing SA, Launceston General Hospital, the Department of Health in Tasmania, John Hunter Hospital in Newcastle, and Population Health in the Hunter New England. So when we're talking about preventive health in pregnancy, we're really interested in those outcomes, those risk factors that have really a beneficial outcomes for women and babies, both for pregnancy, birth, and then kind of ongoing through childhood and adulthood. So it's recognised that not smoking during pregnancy, not consuming alcohol, maintaining a healthy diet, and maintaining physical activity have really ongoing benefits for the pregnancy, birth, and child and mother long term. However, general kind of Australia-wide evidence suggests that during pregnancy in Australia, around 10% of women or people smoke in pregnancy, around 15% consume alcohol, 90% do not meet dietary recommendations, 70% don't undertake recommended physical activity. And those last 2 are probably not unsurprising given kind of what happens in the general population as well. And those last 2 risk factors also contribute to around 60% of people who are pregnant gaining gestational weight gain outside of the recommendations that they've been given. There are some general clinical practice guidelines at the national level that provide some guidance to support clinicians who are providing antenatal care, to support pregnant people to meet those recommendations. They tend to follow 3 key steps. So an assessment or asking about the health risks and health behaviours, providing advice based on what's recommended and the benefits, and providing help that might be needed to further support people during their pregnancy, especially outside of those antenatal visits. So that might be referral to existing support services within the community or at a state level, and also other supports such as nicotine replacement therapy for smoking. However, we also know that less than 10% of women or people in pregnancy receive this care currently. So with all of that in mind, we had many aims for this project that we undertook. So we wanted to determine, given that there is that kind of national guidance, how do you translate that to a local level? So how do you take that national antenatal clinical guidance and what does that look like for a functioning maternity service? We then wanted to look at what the current implementation of preventive healthcare in pregnancy looked like at the sites. What were the barriers and facilitators to the provision of that care? What implementation strategies could be used theoretically to support improvements in care? And also we wanted to determine the potential effectiveness of those strategies in actually improving care. And we worked with 3 maternity services across the 3 states that I acknowledged before. And all of those projects were undertaken in co-production with the policy and practice partners at those sites. So the first project that we undertook, as I mentioned, was to really take those general guidelines and look at what they should look like or could look like in a functioning maternity service. So we undertook a co-design process where we did a desktop review of guidelines that existed at the national, state and local level, and there were many of those. And then we married those with some considerations of local context. So we looked at what services were actually available for referral at a local level, and they may also have been services that existed at a state level, such as telephone support services. So we wanted to look at what was available for people attending that particular maternity service. And then we also needed to consider the antenatal schedule of appointments in terms of the opportunities that antenatal clinicians had to engage with people during their pregnancy and to provide some support. We developed 3 care pathways for each of the 3 services that we were working with. They're all available on the TAPC website, so I won't go into the detail of those. There was one for alcohol care, one for smoking, one for gestational weight gain, which covered both physical activity and diet as well. What I'll point out are just sort of what the key features of those pathways were. So they followed those 3 steps of assessment, advice, and help. They all recommended routine care for women, for all women that attended maternity services, so that that care was consistent and that everyone had the opportunity to engage in that care, and that that care start at the first possible opportunity, so the booking in visit or that very first antenatal interaction. That a standardized, validated tool be used for assessment, whatever, it was valid for that topic, that the advice be in line with those recommendations that I spoke of before in terms of what was recommended to improve outcomes, and that help be really provided in terms of what was locally available and as many options for people to participate in that further referral. So it could be face-to-face or by telephone, as well as linking into appropriate cultural supports. We also indicated that for each of these pathways, there was a need to follow up after that initial antenatal visit, which is really busy in most maternity services, and to provide some follow-up care throughout pregnancy. In terms of the gestational weight gain pathway, just to point out that that did include both physical activity and diet as well. And for the smoking pathway, I just wanted to also acknowledge that we incorporated carbon monoxide monitors as an assessment tool where we could, so where they were available and could be integrated into the service. that for advice, it was relevant to include both smokers and recent quitters in those discussions, and that arranging help was not only just referral for smoking, but also potentially offering nicotine replacement therapy where that was available at the sites. So in terms of what those care pathways look like between those services, we did notice some differences. So just in summary, the assessment tools were different at some of the sites, and that was really based on the availability of tools that were already in practice at the sites, and also some of the timing of the assessment differed, and that was largely due to the antenatal schedules being a little bit different in terms of when women were accessing the services. In terms of advice, it was relatively consistent, which is great to see. In terms of help, that really again was different, and so in terms of project 2,
Hi, Mel. Can you hear me? At least at my end, I think we may have lost you.
oops.
There we go.
Oh, can you?
You're just
Oh, can
frozen.
you hear me now?
Yes, you're
Hello.
back
Oh,
now.
okay. Sorry. Let's speed through. Thank you. Can you still see my slides?
We can, yes.
Okay, great. So just to, talk through the second project. So we wanted to find out what the current receipt of care was at the sites, and also to work out what the prevalence of those health risks were at each of the sites. We very early found on that the best way to do that was to talk to women after they had attended an antenatal appointment. So we called women up. They also had the opportunity to do the survey online, and we asked about their health risk factors, but also assessment advice and help that they received during that recent appointment that they attended. And we were able to conduct surveys with around 1,000 women for this project, and people across those 3 sites. And this is what we found. So we found that, and what you've got there in the columns are the 3 different sites in those 3 different shades of green and yellow. In terms of current smokers, about 2 to 8% across the different sites of women said they were currently smoking. There was an additional 5 to 10 time in the last 12 months, but for a lot of those women, it was just during pregnancy. About 4 to 5% disclosed current alcohol use, and around, I suppose, 2/3 of people were currently gaining gestational weight gain outside of their recommendations. When we looked at the current reported receipt of care, in terms of smoking, and actually for all of the health risks, there were key differences between the sites, so site to site in terms of whether this was currently routine care, but also differences between those elements of care. So for instance, with smoking, current assessment was actually relatively high and kind of had made its way into routine practice. Assessment as to whether someone had recently quit was lower, as was advice, and that was quite varied between the sites. And help really was only provided substantially to women at one of the sites for smoking. If we move on to alcohol, again, really different between the sites, just indicating that for some of these sites, it was already routine to do some of this assessment and care. For some of the sites, it wasn't yet. And when you looked at help as well, we can see that only one of the sites was really providing additional kind of referral and support for alcohol use in pregnancy. And again, gestational weight gain, physical activity, and diet care was also very different between the sites. And actually more in particular different between those elements. So you can see that for assessment, again, there were differences between the sites, but that was kind of the main thing that was being undertaken in terms of women were being weighed or offered to being weighed during pregnancy, but then there wasn't really any follow-up advice or help provided at that point in terms of physical activity or diet. And definitely not really any kind of referral services offered as a routine part of care. So that's the end of the slides that I have. So I'm going to hand over to Sophie, and she'll take you through what we did with all of this information that came out of the first two stages of the project.
Hi everyone. As Mel said, my name's Sophie Dilworth, and just before I continue, I also wanted to acknowledge the Awabakal people whose lands I'm coming from you today, and pay my respects to elders past, present and emerging, and extend that to Aboriginal people on the webinar joining us today. So I'll pick up on project 3, and this project, there were 2 elements to it. So we were looking at the barriers and enablers to providing the recommended care that Mel's just talked about. The first part of that was a mixed methods systematic review that we undertook. Well, we're still working through that. There's 48 studies in the review from 2001 through to 2022. We had 2 coders independently screen and code the findings of each of those papers or those studies into the theoretical domains framework. And the studies came mostly from USA, Australia and UK. There were 22 papers that looked at smoking, so a lot of work has been done in the smoking area, 18 in gestational weight gain, healthy eating and physical activity, and 8 looking at alcohol consumption. So the other thing, we looked at preventive care in routine antenatal care. So we looked at samples that included midwives, multidisciplinary teams, obstetricians and gynecologists, GPs, and then there were some studies that included kind of mixed samples of medical officers, or they weren't specified what sort of discipline they fit into. The other component of that, sorry, my slides are not clicking through. Oh, there we go. Was a parallel mixed method study. So we spoke to clinical staff at the 3 sites that we were working with. We managed to speak with or survey 154 of those staff. At one site, we used the best worst scaling method to identify priority barriers at that site. And at site 2 and 3, we looked at the frequency of the behaviour according to the care pathways that we had developed, and we asked about the barriers to any of those behaviours that staff told us they were not performing routinely. And at site 2 and 3, we also did interviews with managers, and we had 7 of those interviews. And the findings from that mixed method study were also mapped back to the TDF. So today I just thought I'd talk you through some of the barriers and enablers that have come through. Some of them came through quite strongly across all of the care components and all of the health risk behaviours. So the first one that comes through quite strongly across all of the work that we've done is the beliefs about consequences domain of the TDF. So that's where staff tell us that there are other things that are taking higher priority in antenatal care rather than addressing preventive health risks. So that's where staff are kind of not prioritising these elements of care. And the sorts of things we saw come through were health professionals reporting that their weight, for example, would be the last on their priority list. So this is an example from the systematic review, and it's related to gestational weight gain, and it's from a staff member in a multidisciplinary team. The other thing around beliefs about consequences is that concern that women don't actually want to talk about these things, and it will be uncomfortable for the staff member if they have to do that. So the staff at one of our sites in relation to gestational weight gain said, if it's going to make it worse, then why would I bang on about it? So there's that sort of discomfort there for the health professional. The other thing that came through, and the domain that came through across all care components and all health risks, was the environmental, contextual and resources domain. So that's lack of time within the structure of the antenatal appointment. So anyone who's a clinician or antenatal care provider will know that those booking in visits and antenatal appointments have a lot to get through. So these are the sorts of things people said about it. So space, time, funding, who's going to organise it, and the implementation issues. There was also limited access to resources. So as Mel mentioned, at the different sites, different referral services were available, and access to those was differed as well. So at one site we had that they didn't have a dietitian in the hospital who would take referrals for outpatients. So there was no support where they could refer antenatal clients to get the help that they needed. Then there were other barriers that were specific to different care components and health risks. For example, memory. And this was where people, for example, told us that they would forget to do a follow-up assessment. So they might, as Mel showed you, the reported reports from women said that they were having assessment done often at that booking in appointment, but then it wasn't being followed through the care pathway. So staff just told us that they simply forgot to do that. The other domain that comes through across different health risks and in different kind of ways is the optimism domain, and it usually comes through as pessimism from the health professionals, and it's around believing that women, for example, won't take up a referral to the quit line. So the health professional doesn't provide that sort of care because they don't believe that it's going to be taken up by the woman. And this was an example from the systematic review. So a health professional from a multidisciplinary team told us that, well, not us, but they reported that no, they don't think their lame diet cancelling is going to make a difference. So that creates a barrier for them in their practice. So following the identification of the barriers, we looked at the implementation strategies that would support the recommended care that we had mapped in the care pathways. The development process involved looking at the barriers that staff had highlighted, identifying behaviour change techniques that would address those barriers, and then working on the implementation strategies based on the EPOC and ERIC taxonomies to try and change that behaviour. So these are the behaviour change techniques are kind of the active ingredients in that process, and the implementation strategies are the delivery vehicles. So I'll just give you a couple of worked examples, and these are the examples that we then took through to the pilot that I'll explain in the coming slides. So as the first example, we had the barrier identified by staff around, so this was around referral to a telephone coaching service for healthy eating, physical activity and gestational weight gain. So staff told us that they weren't necessarily performing this behaviour all the time, and the reasons they weren't doing it were that they didn't have the referral resources. So that's the barrier that they identified. That fits within the TDF domain of environmental context and resources. And the behaviour change technique that maps to is to add objects or restructure the environment. And to do that, you need to make physical changes in the equipment available to staff. So the next, and I'll show you how that practically was applied in the next slide. The next barrier that staff told us about was that they didn't know what to do, and they didn't know of any referral services. So this was a knowledge barrier. And so that maps to the TDF domain knowledge. The behaviour change technique that we looked at was instruction on how to perform the behaviour. And the implementation strategy we used was educational meetings and materials for staff. And the last barrier that we focused on was that staff told us that they forgot to do this. So they would forget to do the referral. So that fits with the domain memory, attention and decision making. And the behaviour change technique is to provide prompts and cues. And the implementation strategy is around reminding clinicians. So we took all of that, and we had worked with our partners to identify that was the area that we wanted to work in. And these were the implementation strategies that we developed to address those barriers. So the first one was around changing the physical environment and what staff had available to them. So we identified that there was a referral form that we could pre-fill most of the information for the clinicians, and we made that available to clinicians in the medical record. So they had a hard copy available in every medical record. We made sure that it was available around the clinics as well, and also saved copies of it to the shared computers and with the administration staff too. So if there was, if it couldn't be located, it was kind of around in a few different places to find. We also added resources to the clinical environment and medical records for women. And then we had education, so that was around the knowledge barriers, and we had the wonderful Liz Wickham who delivered that education. Liz also was responsible for these other implementation strategies too, so working with each of the teams to make sure that they had those resources available, making sure everybody knew about the service, the benefits of the service, and how to perform that referral process. And then our last strategy we used was around the reminders. So you can see the form that the clinicians work with here for their first visit. It's very busy. Each one of these little tick boxes is actually an assessment or a full conversation that the midwife needs to have. So it's a lot. We developed a sticker that was colourful, and Liz worked with the volunteers to get one of those on each of those forms in the folder, ready for booking in, so that they could do that as part of the booking in assessment. So as you can see, these are tailored to the identified barriers. They were developed using a theoretical framework and evidence to support the approaches that we used, and they were feasible within the context. The next slide that I'm going to share is just an outline of the pilot and the results of the pilot that we undertook. So we used all of that work that Mel and I have described to you, identifying the areas of practice that could do with some improvement, the barriers that we identified with staff, and then using that implementation strategy development co-design process. And we put it all together and did a pilot with one of our sites. You can see here in September is when Liz started working with us on the ground at the site and implemented the strategies from the previous slide. And that implementation period went from September to October. And you can see there was a big uptake of the service, and we did really well with those strategies. And yeah, so that was a really good example of how some tailored implementation strategies could be used to change practice in that specific area. So just wrapping up, the project provided us with a blueprint for co-designing clinical improvements and initiatives to prevent chronic disease. So we used that same process at each of the 3 sites. We used it across different health risk behaviours. We tailored it to different barriers, and it was a process that seemed to work well. The co-design local antenatal care pathways kind of formed the base for all of that work to build on, and understand what was happening in terms of recommended clinical care at the time. It gave us an opportunity to identify the barriers and enablers to support practice change in those areas, and co-design implementation strategies to support that recommended care that also were tailored to the needs of the sites. And then we were able to test the feasibility of those strategies at one of our sites. So that's it from me. Again, I'd just like to acknowledge our funding partners and do a little promotion for the Prevention Centre. So the Prevention Centre website has lots of information and about this project, and also you can sign up for their regular newsletter to get updates from the centre. And then I will hand back to Luke, and you can enter any questions in the chat or raise your hand to be able to speak with the panel. So I'll just stop sharing.
Thanks very much, Sophie, and thank you, Mel, for both the insightful and really clearly articulated presentations on an impressive program of work. So we're now at the panel discussion component of the seminar. So as Sophie said, I'd encourage you to pop questions into the chat, and I'll monitor the chat and ask questions on your behalf. You can also raise your hand. So we've heard now from the researchers. I'd also like to hear, of course, from the partners in this program of work. And so I'd like now to invite Angie Wilson and Natasha Strands to join Mel and Sophie on this discussion panel, or virtual discussion panel. So Angie was formerly the Midwifery and Nursing Director with Women's and Children's Hospital in Adelaide, and now with Flinders Medical Centre. And Natasha is a manager with the Prevention and Population Health Directorate of Wellbeing SA. So welcome, Angie and Natasha. So I will kick things off, perhaps with a question to our partners, Angie and or Natasha. Can you tell us about your experiences of them being involved in these projects from your policy and your service perspectives?
Do you want to go first, Angie?
Yeah, I'll go first. So I think from a unit point of view, you know, we've got procedures and policies in place, and you think you're doing all the right things, and I don't think it's very rare that you actually stop to look at what are the barriers, and what's stopping referrals, and whether you actually monitor that. Because we have to do so many audits, some things you don't stop and think about, you know, topics like this. So for us, it was really good to be in that co-design of the research. I mean, we do quality improvements all the time in healthcare, everyone does, and you kind of, you know, you've got to be, you are at risk of being quality improved, exhausted. So for someone to, you know, like the research project, to then come in and say, look, we're going to help you, we're going to design it, we just want you to kind of be engaged. It was so easy. And it was because it was in our own backyard. It's engaging the midwives in research, which I think is a really important aspect of, you know, getting research into clinical practice. You don't have to be an academic to do research. You can be involved at the ground level. And everyone was so energized and really interested to find out what we were actually doing and how that impacted women. And, you know, co-designing the new pathways and the resources, everyone was really engaged, and it was quite exciting really to then look at the results. Chart that you popped up, Sophie, we had a, you know, a good referral rate, but the uptake on the advice and the enrollment in the program wasn't as good. But still, you've got to think that all those women were then getting that added advice about healthy weight gain in pregnancy, alcohol consumption and weight gain. So it was a really good project to be involved with. And as I say, you know, we really need to get research into the clinical areas for midwives to be engaged, you know, for them to go through that process. And then maybe, you know, it inspired me to do some research. So I've never done any research before, and we're about to embark on some research ourselves. So from that point of view, it was really good. And for midwives to be at that forefront with the project, you know, and we all say, don't we, you can read a research project and go, yeah, but when it's in your own backyard, it kind of means a whole lot more.
Thanks, Angela. They're really interesting perspectives. Natasha, do you have anything to add to that from a policy perspective? Yeah,
thanks, Luke, and thanks for that perspective, Angie. It's really great to hear, I think, continuing to hear, because we always get insights every time we get to chat about this project and sort of what the positives and I guess next steps are. But from a policy perspective, for those that aren't aware, Wellbeing SA is, I guess, the state's preventive health agency for South Australia. And it was a really great brokering, I think, by Tapsy and Sophie and Melanie and the team to kind of bring both us and the service providers as in the Women's and Children's Hospital together to really kind of focus in on how do we build our partnership as well, and how do we work better together, not only for this project specifically, but into the future. Because I guess as the preventive health agency and policy arm, it is kind of, we can be very somewhat disjointed at times with the health service level, and really it was about us checking ourselves and working out, well, what support can we provide on the ground. And luckily through that implementation phase, it was around supporting increased referrals through the program that we were supporting, and what can we do from our end to support some of those implementation strategies specifically, whether it be supporting the education element or the increased resources or specific elements that could be included to make the environment, I guess, more conducive to those referrals, etc. And I think it also helped us to better understand, I guess, the on-the-ground challenges. So we weren't necessarily just sitting in an ivory tower going, this is what we need from a prevention point of view, and this is how it needs to happen, this is what the evidence is saying, but really kind of getting into the thick of it and understanding what the on-the-ground challenges are, so that we could then layer that on top of the evidence base that obviously we went through in the first parts of that project. So yeah, that's just a bit from our perspective as to the benefits of being a part of the work.
Thanks, Natasha. I think a really interesting part of this collaboration is the multi-level nature of the partnership, both the service and policy level, as well as the partnership with researchers. So I might come back to that. We have a question from Stuart. Sophie, this is to you. It's in the chat about the smoking cessation care pathway that was developed. Did it provide any guidance around vaping, or could it be updated to include some guidance around vaping, given the rise in vaping prevalence?
Mel might be able to speak to this more. So there was some information about vaping, and then I know locally in the Hunter now the pathway specifically talks about vaping. And Mel, I know that you have more information about the vaping stuff that's happening at the moment.
Yeah, so definitely agree. These pathways should all be updated to include, in particular, vaping, as I suppose policy guidance comes out around what is the best practice. So in New South Wales, there is a new policy directive that's come out around smoking and vaping in pregnancy and for the newborn, like to improve newborn outcomes as well. And so we will be taking that and looking at implementing that, obviously throughout New South Wales, but in particularly at a local level. But yes, definitely something that we need to keep moving with and make sure that that's incorporated. We're doing a little bit of work to identify again the proportion of women who are vaping in pregnancy, and yes, it is an emerging issue that needs to be looked at, and women that might be still vaping and smoking cigarettes at the same time. Yeah, thank you for that point.
Thanks, Mel. Jennifer, I think you had your hand up.
Yes, thank you. And actually, you may be able to clarify a few points in these questions. I just had two questions. One, just around the co-design process. I know that throughout the academic world and in this, there's sort of purists in what co-design actually kind of relates to. And so I'm just really interested to learn about the sort of process of that co-design. And how that was achieved. And then just my second question was just in terms of your implementation. Am I right that this was across all the partner sites? So you're obviously in different sites, because I'm just intrigued around any sort of context specific kind of nuances that you came across, and about, your pathways look excellent. Did you actually come together collaboratively to decide that was right, or did you have to kind of make some context specific adjustments throughout your implementation? I hope they made sense.
Thanks, Jennifer. Who would like to take that?
Sophie, do you want to talk about the co-design and I can talk about the context?
Yeah, so the co-design process, we had working groups at each of the sites who we worked specifically around their individual, the localised care pathways there. So, and the working groups met throughout the project. We did lots of, we had really regular meetings, and we had some subgroups around the specific. So even for each of the specific care pathways, we would have people who had a specific interest in, for example, smoking. We would work together on that pathway specifically to develop that. And it was around kind of looking, as Mel described, looking at what's available nationally and guiding practice at that level. Then how is that informed by the state policy, because at times they're different as well, and then working with the site saying, well, what are you actually doing here? What local policy is guiding your practice at the moment, and how does that fit with what we're seeing in those tiers above? So it was a very I guess it was locally driven. So we kind of, as the researchers said, well, this is what we can see exist in the public domain and in the state and national guidelines. What's happening here? So we really relied on our local sites to identify, what's happening in their local systems, what's their local governance around different things, what services are available, those networks that happen locally to support that. And then the co-design around the actual implementation strategies was, as the researchers, we had the information about what pregnant people had told us about their care that they'd received at the site. We had done the work with the staff around the barriers and enablers. So we presented that back to the sites and worked with the individual sites and said, these are the things that people have told us. Where's the appetite for change? What resources can we utilise? How can we best do this? So it was very locally driven by what was available, what their priorities were, and what was achievable within the context of a pilot study. So I think maybe that has kind of addressed the co-design stuff. If there's more specific questions, I'm happy to talk about it out of session as well.
Oh no, thank you. That's great. Thanks, Sophie.
And just to add to that, just in terms of context, yes, the sites were really different. So they were different sizes. They had really different say medical record systems. Some of them were electronic, some of them weren't. So of course, we had to take a lot of that into consideration. There were different types of antenatal teams providing care at each of the sites. Some of them had more medical staff because they were tertiary kind of referral hospitals, and some weren't. We also had some of the sites where the first antenatal visit occurred much earlier than some of the other sites. So that really does change maybe what that assessment is and what stage of pregnancy you're at that stage. So all of those things definitely had to be taken into account in developing the model and when it should actually be implemented throughout the antenatal period, but also in terms of what implementation strategies could be put in place. And I think the other point I just wanted to make was that the availability of referral services was really different. So while everyone struggles for face-to-face dietitians, that's kind of fairly standard, there was really differences in the availability of the carbon monoxide monitors, the availability of the Get Healthy service that wasn't available at one of the sites, it was available at the other two. So yes, really different contexts, and they all had to be taken into account throughout this entire project.
Yeah, thank you. No, I'd love to touch base with you offline. I'm trying to do something similar
Yeah, sure.
in this
More
space.
than happy to.
Yeah. Thank you.
Great. Kate, I can see your question, the comment. I'll get to it in a moment. I just want to follow up on some of the discussion we've had. So I'm going to ask a question of my own, if that's okay. So, I mean, this is a really interesting partnership project. And it's clear that there were some differences between sites in terms of the contextual factors. I guess I'm interested in how the partnership operated. So whether this was, a series of independent, almost independent projects on the same topic in different sites, or were there structures in place for collaborative gain? So, were learnings from one side applied to learnings of the other? Was there, did the service, maternity services, different sites, were they connected in any way, or the policy agencies in each site? And just how was there, just can you talk more about the nature of the partnership across sites rather than within each jurisdiction?
So I might just add to start with that there were definitely learnings that were taken from site to site. Like the first site that we worked with, we obviously developed a lot of the processes that could then be taken to the other sites. I suppose Sophie and I were probably the main carriage of information and transferring that. We often talked to the sites about what was happening at the others, and that enabled kind of discussions to flow from site to site. I think it would be ideal to, like we had talked about kind of linking the sites together, and that's something that we probably, you know, hopefully will still do in an ongoing way. And I think there would be huge benefit in that. There was some, you know, obvious disruptions through COVID in enabling some of that to happen. However, yes, I think that there would be huge gains made if this could be more collaborative across the sites as well. Sophie, did you want to add anything, or Natasha or Angie?
I think that would be really good, Melanie, to get some, you know, real good collaboration going, because now we're all going to move on. Obviously, you're going to step back, and we need to make sure we keep momentum going. So I think linking the 3 sites would be good, so we can share, you know, ideas for keeping that momentum going, and then any barriers to keeping it going. I think also as well, Wellbeing SA, it would be really good to get some good collaboration going within South Australia as well with the other sites that provide antenatal care, because it's quite transferable to all units. But I think we need to keep that monitoring going to make sure, you know, we are keeping those referrals up. So I think linking all the sites, you know, within a jurisdiction as well that haven't been involved would be a good way forward as well.
Yeah, I think just to add to that, I guess some of the work that's continued on from this is around the carbon monoxide monitoring that was not available at some of the sites, and it was also impacted by COVID. But so taking the knowledge that we have and the strategies we use to implement that at other sites, and using that to help the different sites get set up in that area as well. So there is still continued collaboration and learnings going on there. I think it's always something that there's a lot of work that could be, I mean, there's a lot of gains to be had there. It's very, I guess it's quite labor intensive, or, you know, you need to have a lot of engagement and collaboration to continue that work, which I think we have from this project, and as we have got work that's still continuing with the site, so that's really exciting. You're muted, Luke.
Oh, mute. Sorry, thank you. Judy, you've got your hand up.
Hi, this is Judy Parish from Launceston in Tasmania.
Yes.
Hi, I just wanted to take this opportunity to thank this amazing team that have gone over and above everything that you could have expected. When they first introduced this opportunity to us, we couldn't believe that we had that opportunity to be a part of something that was so amazing, that it was something that we couldn't have driven ourselves. And to be led in that process was really, you know, just unprecedented. These poor guys, they started this project, and then we entered the most unprecedented amount of distractors and change. Not only with the world and the COVID, but also we had a lot of key people changing in our place. We changed our physical environment that our care was being done, building units and moving and goodness knows what. And all of this provided all sorts of levels of distraction. But these guys kept us on track all the way through. They were endlessly patient and kind. They didn't say unkind things when we said, oops, sorry, forgot. Oh dear, is it that time already? They kept us on track, and we achieved a lot in that time. We realised that our staff just could absorb everything that every resource that we're able to throw in that general direction, and that was a tremendous benefit. The possibility of sharing resources and training was amazing. We can do so much more together than we can when we try and chug away in our own little silos. So, you know, what we learnt about the co-design in that, you know, is a map for future processes. And, you know, this was a team that hadn't been involved in clinical research, and this was an introduction to that. And I'm sure the team that started this didn't think that they would have to teach us that as well as design a program and conduct the research. So just from someone on the ground, I want to say thank you so much for everything that you did, and what a privilege it was to be able to share the process.
Well, thank you, Judy. What a ringing endorsement of the collaboration. You know, this is a model, but also importantly, you mentioned that the people involved in it and the way they went about engaging partners. So, you know, that's a fantastic comment on everyone who's been engaged in this project. So thanks for providing that. I mean, I've also reflected on, this was a partnership brokered by the Prevention Centre for partners who had never worked together to come together and work together at different levels. And so, you know, this could have easily gone awry. Partnerships are often very difficult to form and maintain. And this looks to be a project that has done that exceptionally well and produced an output that's been valued across all those levels, from a knowledge generation perspective, but also a service and policy perspective. And so I wonder, just to follow that comment, Judy, you may want to add something here as well, beyond what you've already said, but the other partners or researchers involved, you know, do you have any comment or advice for those that are seeking to enter into similar partnerships about, you know, what you see as the key ingredients for, you know, fostering productive, well-functioning collaborative initiatives like this?
I'm happy to go first if that's all right. I think there's kind of two elements to that, Luke. I think it is about the nature of the relationship and sort of the openness and the willingness to really be kind of listening to each of the partners' needs and objectives and those sort of things and barriers. But then I also think it speaks to the very pragmatic kind of logistical side of keeping a partnership like this functioning, and kind of just the mechanics, the moving parts. So I think it's really important up front. We were so lucky with Sophie and Mel and the team that they kind of took on that burden in this instance around the logistical admin, you know, organising meetings, all the stuff that we don't think about when we think of partnerships. We just think about it, the great conversations around a virtual or physical table. So I think it is about establishing those kind of roles and responsibilities around the partnership mechanics in the first instance, to make sure that, you know, there's going to be a meeting schedule, that we are going to have recurring times to chat and those sort of things. And then I think it is about just really having clear expectations from all partners around what the objectives of being a part of this partnership is, and what the benefits each partner sees in being involved together, and just having really clear line of sight as to that, and rechecking in as to if it's, you know, meeting your objectives, so that each partner feels like they, I guess, have a place at the table and a reason for being there.
Thanks, Natasha.
From the clinical point of view, it was also having the resources on the ground as well, with the appointment of the research assistants, who were midwives who've never done research before, but had very good mentorship and really engaged. But if we hadn't have had that, it would have been really difficult to then fit that in your normal busy work life. You know, in a very busy antenatal clinic with such competing demands. So having that was a real good resource on the ground, and that kept the momentum going from a day-to-day point of view as well.
I might just add to that too, that I think at each of the sites we had really good engagement throughout the organisation, so from leadership right through, and that was a really important thing, I think, that kept the collaboration going, but it also was a good way to, I guess, show that it was a priority, and it meant that people stayed engaged with it as well. We had other pilot projects that happened as well as part of it, and I think being able to have that leadership meant that people could easily identify that it was a priority, and then it was okay to link in with the project and with us as a team and commit some time to that as well. So I think that was another, it wasn't it was kind of throughout the organizations that we partnered with. So that was something that I thought was really helpful along the way as well.
Yeah, and I was just going to note that from a, I think, research perspective, in hindsight, what worked really well is that we went in with a very flexible protocol as to what we were actually going to do with this 2 years. So we were able to then really adapt to the needs of the sites. We didn't go in already with a preconceived design, a preconceived idea of what the topic was that we were going to work towards. It was chosen by the sites to kind of investigate further. And I think that really enabled the project to work well, because we could truly take on board the perspectives of all the partners, rather than kind of sit there with our rigid kind of protocol ready to be implemented. So I think, yeah, and in hindsight, that was really great, like having, and that was I suppose the flexibility of the funding that TAPC enabled as well, which I think has huge benefit. Often when you put down an NHMRC grant, it's quite, thorough in detail as to what you're going to do. Whereas I think with this work, we're able to propose something that was able to evolve over time, and we had the privilege of that being funded. So yeah, that was, I think, from our perspective, a big win. Yeah.
Thanks, Mel. There's a question from Kate. Can you talk to any adaptation or modification to the model of care for cultural, different cultural linguistic groups? Did that occur, and how did that happen?
We did meet with some Aboriginal groups and tailored the discussion and advice specifically for Aboriginal consumers, which did work quite well. We did have a specific care pathway for Aboriginal women in an Aboriginal family birthing program. So that did work really well, and they were supported through that from Aboriginal health workers within the division as well. But I don't think there was any other cultural groups that were specifically targeted or evaluated. They were in with their normal population.
Great. Thanks, Angie. So we're just about at time. So perhaps this is just a final question, and probably for Natasha or Angie, but can you tell us what you think is needed to maintain the momentum from this work from here, to ensure that, preventive healthcare is embedded into routine antenatal care? Do you have any thoughts on where to next?
Yeah, I think it's kind of opened my eyes really to, I think in clinical practice, you get caught up in the risks. We work in tertiary centres, so it's high risk pregnancy, addressing all those factors. But the preventative risks that are open to really address during that pregnancy is a vital time for women. We've got a captive audience. The advice that we could give could actually be long lasting, well after the pregnancy, and really shape the future for them and their children with healthy weight gain. So it's definitely opened my eyes, and I really think that in South Australia, we need to build some long-lasting partnerships with Wellbeing SA. We see you doing this great work, Natasha, in Wellbeing SA, but we kind of really need to get those links really down to the clinical practice areas. So for me, I think building that relationship with Wellbeing SA, and now we're working a different organisation, I can see benefits of rolling that into the other tertiary centres as well, and into rural country health. So I think we need to get our heads together, Natasha, to see how we can do that from a state point of view. Take it to state meetings, get auditing going, long-term auditing that we can benchmark against, that we can really, be monitored against, get those good standard practices, what we've done across the organisation. I think that for us is a real kind of drive for me now.
Thanks, Anne. Natasha?
Yeah, just quickly, I think you've hit the nail on the head. I think it's about how do we really embed the partnership approach across the state, not just with, the original kind of research team and the research project, but more broadly. And I think that speaks to kind of having some really strong partnership, I guess, foundations in place. So, you know, how do we establish some governance around some really strong partnership mechanisms? How do we keep that conversation going so we can be open to opportunities at different sites? And how do we keep the kind of current work just still progressing and ticking over, but then open to other opportunities as they become apparent, just so that that prevention conversation doesn't fall off the table and gets lost in that busyness. So I think it is about maybe putting our heads together around how do we really knuckle down on the partnership approach, because I think from there as a foundation, the rest will kind of come in terms of the busy work.
Great. Well, thanks, Natasha. And, you know, we're almost at time. So can I just ask everyone to join me in thanking with a virtual clap all our presenters today. It was a really fantastic presentation. We covered a lot of ground. I think one of the key learnings from this event was the importance of partnership and its potential to have value and expand the networks and capacity amongst all of those are involved when, you know, when it's undertaken well. And no doubt partnerships like this will yield improvements in mother and child health. So thanks everyone for attending. It was a well subscribed event. Thank you TAPC for hosting the event and for funding this work. I hope you all enjoy the rest of your day.